This is Residents in a Room, an official podcast of the American Society of Anesthesiologists, where we go behind the scenes to explore the world from the point of view of anesthesiology residents.
We're slowly building those blocks of supervision. So it starts with bringing in the PGY1s.
How do I work with the 3 anesthetists that we have? Are they getting breaks? Have they gotten out for dinner?
One of the biggest skills that I recommend applying as you go into a new practice is asking questions.
Something like a simulation and maybe management of multiple rooms would be helpful.
Hello, and welcome to Residents in a Room, the podcast for residents by residents. I'm your host, Dr. Alexandia Daniels, a CA1 from Tidal Health in Salisbury, Maryland. I'm joined by a few fellow residents and by Dr. Matt Hatch, a member of ASA's Committee on Anesthesia Care. Today, we are going to talk about room supervision, which is something we'll all need to understand well as we transition from resident to attending. With that, I'm excited to get started. First, let's meet my fellow residents.
Hi, I'm Shivana Ramsingh, PGY1 at the University at Buffalo.
I'm Kevin Flood, a CA2 at Emory University.
Lovely. Dr. Hatch, why don't you go ahead and introduce yourself, tell us and our listeners a little bit about your path, your role, and your committee work.
Thank you. Again, my name is Matt Hatch. I'm currently in private practice in Winston-Salem, North Carolina. And I think we all have unique pathways, but I think my pathway to where I am today is really, I think, helped shape me to talk about this transition because I've had several transitions throughout my career. So I did my undergrad at WashU in St. Louis, then went back to my home state of Indiana for my medical school training. I also did an MBA during that time. It was one of the early 5-year MD MBA programs to kind of understand a little bit more about the business side of medicine. I then proceeded to do my residency at Wake Forest University in North Carolina, then stayed on to do a fellowship also at Wake Forest in obstetric anesthesia. I then stayed on as faculty at Wake Forest for about 9 to 10 years. And then an opportunity arose where I made a transition into private practice. So I went from academic model to a private practice model, which are similar, but also have some distinct challenges to both. I also have done some moonlighting now at a new institution at MUSC, which I'll be starting. So again, several kind of hops of new practices, new experiences. So I've been involved in the ASA since I was actually a medical student. I think I was one of the first medical students ever to attend the ASA Legislative Conference, and have always kind of felt the calling to help out the global field of anesthesia, not just my own personal experience, but kind of just seeing what the whole society as a whole is doing. I have served as an alternate delegate, a delegate, served on several committees. I am currently, as you mentioned, I'm on the committee on the Anesthesia Care team. I currently chair the ASA Committee on Communications, and I also serve on the ASA Committee on Governmental Affairs. So I think I've spent some time involved in the ASA. I actually just came back from the ASA Board of Directors meeting in Chicago, where I also serve as the alternate director from North Carolina. I think all of these roles, both professionally in my day-to-day job, but also for the ASA, has really given me a good perspective on the different types of models of anesthesia, and also just thinking about the future of anesthesia and how we're going to be practicing 5 to 10 years from now. I'm so thankful for this opportunity to talk to you about my experience and these things and kind of advice I can give and helpful tips I can hopefully add to help all residents as they transition from the time of residency to private practice or academics or wherever you find yourselves after you finish your residency or fellowship training.
Perfect. Thank you so much for that. And we're so glad to have you today.
So, Dr. Hatch, what's it like going from sitting your own cases to managing cases? Can you talk about this transition and what we should expect as residents moving into attending herd?
Wow. I mean, this is such a great question. It was probably one of my biggest, I'll be honest, fears after I finished residency. And I do want to take a point to step back and say, I think a lot of what I'm saying is directed at those of you who are going to be going from a sitting your own cases to then supervising or directing anesthetics. I really think this is probably one of the most challenging, but also exciting and satisfying transitions you will probably have in your career if you practice in a team model. I'll never forget a Friday afternoon when I had my own cases to then the following Monday morning when I was covering 4 different rooms. I remember on that Sunday night spending at least 2 to 3 hours looking up these patients and pre-oping them. And I think if you look back at our training, the challenges that you face as you transition kind of make sense. especially if you compare our training to that of other houses of medicine. We're a unique specialty. A lot of our care involves taking care of one patient at a time. I mean, there are some exceptions when you're covering a labor floor, but you're involved in one patient and one anesthetic in your training time. Other specialties, I think like internal medicine, obstetrics, or surgery, for example, you have teams with multiple professionals who are treating many patients at any given time. You're covering a very large service of patients and are dealing with teams on a very large basis from your intern year throughout your training. Yes, surgeons and obstetricians do operate on one patient at a time, but unlike our specialty, they're not really directing 4 other surgeries with 4 other people who are sitting in those rooms themselves. The ACGME realized this was a very important part of your training. I was recently looking up what are the resident requirements for anesthesiologists, and I'm going to quote here that residents are expected to work in interprofessional teams to enhance patient safety and improve patient care quality. Also, quote, they are supposed to coordinate patient care within the healthcare system relevant to their clinical specialty. Quote again, the residents must demonstrate interpersonal and communication skills that result in the effective exchange of information and collaboration with patients, their families, and health professionals. And finally, to quote, they will work effectively as a member or leader of the healthcare team or other professional group. So while the ACGME kind of mentions all these topics, it's a little bit vague on exactly what you're supposed to do to be truly qualified in these areas. There's not really a sense of what do you need to do to coordinate patient care? Or what does it mean to be qualified in working in interprofessional teams to enhance patient safety? You're going to be going from focusing on one patient at a time to working to up to many more and working with many types of people with varying personalities and skills. The skills that are required for you to do this are useful not just in your job, but really in all aspects of life. And I'm talking about good communication, good interpersonal skills, leadership, multitasking, time management, operations. So think about a typical day for you as a resident. I'll use myself as an example because I will not speak to everyone's personal example, but I would call my attending the night before a case. I would go over a plan, talk to that attending about that plan. I'd research the patient's medical issues and kind of my thoughts for the day. Now you transition into post-residency jobs. Imagine doing that now for 4 different rooms with 4 times as many patients, but you're not really usually calling the performing professional the night before to run each case by that person. One of the biggest skills that I recommend applying as you go into a new practice is asking questions. I think that's a huge sign of maturity in someone is that you come into a situation where you may have questions, have doubts, but just asking a whole bunch of questions to get a knowledge that you think is going to be appropriate for that particular practice. I'm more worried about any of my new partners that come in that don't ask me any questions, that those that call me 5 times a night with things on their mind.
Thank you, Dr. Hatch, for clarifying what that transition from managing one patient at a time to managing multiple rooms would be like. And your approach is definitely very helpful to listen into. I think that a senior such as yourself definitely is a great resource for helping us with this, but I'd like to delve a bit deeper into the topic. And I would like to know, are there common mistakes that we should be mindful of, or perhaps something that often surprises early career anesthesiologists about the transition to supervising multiple rooms?
Yeah, it's a very good question. I don't want to portray any kind of a transition as scary. I really saw this as an exciting time. And I really think it is critical as you enter a new practice, wherever that is just to be mindful of the people that you're going to be working with. You're going to meet a variety of people. And this is, again, going back to some of the softer skills of medicine and intercommunication. And they're going to have a variety of backgrounds and a variety of experiences. I mean, some of the CRNAs or CAAs that you'll work with are going to be just coming out of training like yourself. Some are going to be practicing for 20 years and have a very deep knowledge of the care of anesthesia for a patient. As you step out into a new practice, looking inwards and saying, how am I going to interact with each one of these professionals? And how am I going to connect with them both as a professional and as a colleague? I know it sounds silly, but I really think empathy is such a huge underappreciated part of life. Everyone that you interact with, trying to see things from their perspective, you are trained as a physician. And that's a wonderfully great skill set that you add to the anesthetic care of a patient. The PACU nurse has gone through a different set of skills that he or she has learned to take care of the patient in that setting. And so when you are stressed trying to understand where other people are coming from is such a huge helpful step as you transition from kind of a one case at a time to multiple. I really also think something that I would advise people to improve on or try to look at more is self-awareness. You may think that you're describing a plan to someone that you work with, but just be cognizant of how you come across to people. For example, I know that there are things that I do well and things that I struggle with. I have a diagnosis of ADHD. So I have been told by some colleagues I work with that I may come across as rushed or irritated or distracted to patients, to other physicians, to AAs or CRNAs. So trying to just be self-aware of how you come across to other people is such a huge, I would say, help as you go forward. Think about what kind of leader you want to be. Maybe someone that you have either seen in practice or taking parts from a variety of mentors and professionals that you've interacted with, and try to become that person yourself. I'm sure each one of you has seen models from an attending that you think are great and certain actions that you say, man, I really don't think that's a great way to approach that comment. As I was thinking about this talk, I thought about, well, from a physician standpoint, what would be something a resident would want to hear? So I talked to some of our professional colleagues, some CAAs and CRNAs, and said, you know what? If you had a chance to talk to residents, what are things that you have seen that you would advise them to do? One of them said that they got irritated when they felt a young attending would come into a room and say things like, in my experience. I think it's very funny that you are very well qualified and coming in and trying to show knowledge to the OR, and you are speaking to someone who's been practicing for 20 years and coming in and saying things like, well, in my experience, my blocks, I prefer a supraclavicular over an infraclavicular block. And so I think that was one thing that I thought it would be something that I could just pass on from not just my physician perspective, but just from what other colleagues have said that they have noticed that makes a transition harder for them to work with. Another bit of advice I would say is, you are very well trained and have a plan in your mind for how to provide a very quality anesthetic. And I think making sure that you talk about that plan, and if the course of action in the OR changes, that you involve the other provider in the room in that discussion. When I was a resident, I would have an attending who would come in sometimes and adjust the agent and not really let me know that had happened. And so I'm trying to deal with, why is the MAC of the agent lower? Making your thoughts known to both the patient or the provider and saying, you know what, I think we probably should be decreasing our gas because I'm worried about hypotension, or increasing uterine blood flow are some of the things that I had thought about.
So I heard you talk about how communication, self-awareness, and like being the leader that you would want to have are very important skills going forward. I know that you've pointed out that the field of anesthesia takes on a completely different practice depending on where you are, whether it's hospital-based, practice-based. What are some things that we can be doing now in order to be prepared for managing rooms, adapting to the new and unexpected environments, things like that? Any tips or tricks you can share?
So the fact that we're even having a podcast about that, I think, is showing a lot of foresight. Part of our job in anesthesia is preparation. You're being taught how to run an anesthetic for a hip surgery, how to provide a labor epidural, but starting to ask questions of your attendings and other mentors that you know about, what are things that I need to be focusing on going forward? How do they approach the day? I had one faculty member who I really respected at Wake Forest, and just started asking this person, so when do you start looking ahead for your cases for the next day? When do you start pre-opping the patients? And using people that you respect as a start model, I think can be a great first step. There are a lot of programs out there. The ASA has a mentor program that I've actually been involved with people as early as medical school. And it's an informal way just to have people ask questions off the cuff, and things that may come up like, hey, I feel stupid asking this of someone I work with in my current hospital, but there's a guy across the country who I can ask an anonymous question about, hey, Dr. Hatch, what is it like to cover 4 rooms? How do you manage your time so that you're not way behind? Or how do you get stuck intubating this patient, but you've got 3 other ones that you have to start with the next 15 minutes? Communicating, I think, with as many different people as possible. If you ever have a chance to attend meetings like the ASA Advance or even the annual meeting, and talking to other anesthesiologists about what is it like to practice where you are. there really are so many different perspectives, and there's really not a single correct way to provide an anesthetic. You could ask 30 different ASA members to do this exact same podcast, and we'll probably have around 30 different answers of how to prepare for the transition. The best way to have a full set of knowledge is to at least have access to that information, getting their thoughts on how each individual would approach things. Part of the question I also feel is knowing what kind of practice you think you're going to be attracted to. Some people want to sit their own cases, and that's their plan. And so they are attracted to practice models where that is the case. I know people who are very comfortable making a transition. You know what? Sometimes I just want to be stepping back from a role of just providing an anesthetic to now being a leader over multiple anesthetics. And that really appeals to them. And so as you ask the question of, well, how am I going to transition, of just thinking about what kind of practice model you are going to be comfortable in. There are a lot of good resources and good books on leadership and communication. I really like the book From Good to Great, talking about businesses that have transitioned from being average to best and leadership skills there. And so I think anything you can do in residency in terms of developing leadership skills, developing communication skills. And I do know that there are a lot of programs out there now who are realizing the importance of this and teaching that even on a residency level. In medical school, when I did my MBA, the best thing that has affected my professional career was not the accounting classes, not the finance, but it was the soft skills of how do you work in a group? How do you interact with other professionals to get a job done? And again, most of you will probably go into practice with a model that is you not personally performing, but directing or supervising other professionals. And so how you communicate with those people is so key. And so skills that I learned in my MBA of just communications was so much more important than any particular finance that I ever learned. The ASA does have a lot of resources out there about that in terms of leadership material and communications. And I think, that would be a good place to start, but just ask questions. It sounds simple. You're in a training where you are supposed to ask questions, but it's something that even today as a 46-year-old private practice anesthesiologist, the best advice I can give to anybody is continue to ask questions.
So Dr. Hatch, you had mentioned earlier about talking with future colleagues and other attendings on how their days would look as an attending themselves. And I was wondering if you could share with us how you prepare for your days.
Yeah, I'm very happy to talk about that. And again, I'm not endorsing the Dr. Hatch method as the best and only way you should approach a day, but with the experience I've had both in academics and now in private practice, I think I've developed a plan for myself that I think works fairly well. I still spend a decent amount of time the night before looking up my patients. I currently practice in a medical direction model, and so we have anywhere between 2 to 4 rooms to start the day. So I will look up the cases, relevant medical issues, the surgeon that I'll be working with, and also then I will look up the nurse anesthetist I'm working with. I work in a very large practice with about probably 90 to 150 different nurse anesthetists in North Carolina, some of who I don't know because we have a few locums that come in and out. Some are new grads. Some I've been working with since I joined the group. And so knowing the person I'm working with is very helpful for me as I come in to start the day. I tend to get there pretty early. I feel it's very important for you as you're starting out in your career to try to be the first person the patient sees when they come into the hospital after they've been checked in. This really allows you to introduce yourself to the patient. And so I will come into the room and explain my role as the physician involved in their care from an anesthetic standpoint. I also then introduce the team members. Patients come into hospitals and they meet so many faces between, their first time at checking in to being discharged to the floor. And I think one role as a physician who practices anesthesia is to explain the role of all the members of the care team. And so I will introduce myself as Dr. Hatch, who's the physician who'll be in charge of their anesthetic. They will also meet CRNA Joe, who works with me to help take care of the patient. I really try to make a point of highlighting the other person who actually will be in the room with them all the time. I then find the nurse anesthetist, and the first thing I do is ask them what their plan was. I think the best way to get people to kind of open up and talk about their ideas and to feel valued and respected is to say, so what were your thoughts on this case? You will still have a plan in the back of your mind, as I do for all my cases, but I do want to hear what this person had planned. If the plan starts to differ from what you have in mind, that's when I start asking more questions. I also then try to meet and talk with the surgeons, especially if it's someone who I've not worked with before, and just say, hey, I'm Matt. I'm working with you today. I'm the anesthesiologist. Is there anything special that you need for this case? Meeting people on a personal level and, asking for their thoughts on what they need, because even if you have a great plan that you thought, okay, well, in my training, we did all of our neuro anesthetics a certain way, but this surgeon needs them to have something that is completely opposite. And so maybe you had planned on paralysis, but this surgeon always does nerve monitoring. And so touching base with that surgeon, I feel is very helpful for me every day, especially in a new setting, to say, hey, is there anything special that you need for this case? How can we provide that for you so you can accomplish what you have to get done? How does the day look then? I mean, you're starting 4 rooms. How does that actually look? And I think trying to create a clinical environment where there is some staggered start, or at least having colleagues available to help you with things. So I will go to the first room that is supposed to start with the nurse anesthetist or the CAA. We will induce. I kind of make sure that that patient is stable, and I check with that person, said, are you okay? And then if they say yes, I then run to my next room, kind of always thinking about where else do I need to be and prioritizing. Some cases are more complex. Some cases are simple ASA ones that don't need you to stay in the room for the whole time. Knowing when to leave and when to stay is a very hard thing to teach. And these are things that I've learned from just experience. If it's a complex prone case with a second IV, an A line, I may need a partner to help start another room for me. And so I'm very blessed to have a group that does have a little flexibility in our system, that we don't all start with 4 rooms all the time. There's usually always someone available if needed for another induction. After the cases get started, I think that's when you start to work on time management. When do you need to see your next patient? When do you need to circle back to that first room, make sure that they are still stable? When do you need to go to PACU to check on the patient from last night that your partner was taking care of that asked you to follow up on? And these are just skills that you learn with experience. You kind of get to know the feel of your patients, your surgeons, your other colleagues that you're working with, and kind of when to come back around, especially early on, kind of trying to be present and available in a non-confrontational way is the best way I can describe it. So not coming to the room dictating to that person, oh, why didn't you give phenylephrine earlier? But kind of come back and said, oh, so I see that we've been hypertensive. Is that something that's been going on for a while? Builds trust with those providers, and touching base with the surgeon, but being present in the room, I found to be very helpful, of just, showing yourself to both the providers personally performing the anesthetic as well as the surgeon and the whole OR staff. But I will say, it is a lot of work. It is more work than I expected in terms of the charting and the pre-opping. And the patients are just as sick in private practice as they are in academics, which is something that I think I'd always been told by my attendings in academics, that academics has the sick patients, private practice has the healthy ones. My experience has been they're sick everywhere, no matter where you go and what hospital you're practicing in. So I would like to talk to the residents here in the room about, there's a few things that I wanted to kind of get your thoughts on. I talked a little bit and tried to talk about what it was like for me to supervise, but how do you envision a role of supervising? What do you think is going to happen as you transition to a supervisory role?
I think for me, all of us, all of our experience thus far has been in academic medicine. So that's naturally where I can see the supervisory role going, which, like, I think you were talking about, fits more with like medical direction. Like, all of our attendings are directing the rooms that we're sitting. And so that's where kind of my mind goes when I envision myself in a year and a half or so supervising rooms on my own. So kind of guiding the medical management of cases and pre-ops, and making sure the patients are recovering well in the recovery area and so forth. I don't know. I was interested because you mentioned some different types of, like, supervision and medical direction. And I think those distinctions, we don't get to see too much of that in residency. So would you be able to let us know a little bit about the functional differences between that?
CMS has required, there are 7 requirements for medical direction, for them to be medically directing. And unfortunately, for better or worse, this ties back to billing only. It is a billing term, but 7 requirements of a pre-op, being there for induction, for all critical parts of the case, prescribing the plan, all 7 things have to be met. And this can be done in a 4-to-1 ratio of up to 4 sites. Medical supervision is anything that does not satisfy those 7 requirements of medical direction. So let's say for whatever reason, you could not be there for emergence. So therefore you cannot bill. So that would be then billed as medical supervision. That very broad term can apply to any facility that has a physician covering more than 4 sites. So there are practices out there that you may just cover 6 sites with 6 different people in the room, and your job is just to kind of go do a basic assessment. You're all in academic centers, and I had not seen it in practice until I was out in private practice, which has only been in the last 7 years. And so asking those kind of questions, I know the ASA Advanced meeting has a lot of good lectures on this. And so I'll put a plug in for that. If anyone has a chance to go to the ASA Advanced meeting, there are great lectures on kind of staffing models out there. So that's just a brief term on kind of a direction versus supervision, all of which I feel should be part of the training. And that kind of leads me to a second question. So I'd love to ask Dr. Daniels a question. How do you feel residents as a whole are being trained in the transition from sitting a case, personally performing, to going to a supervisory role? Do you feel that you were trained, had some training, a lot of training in the transition of how do you manage an anesthetic across 4 rooms versus 1 at a time?
All right. Well, thank you for that question. So I've just started my CA 1 year. And like for our program, really, we have been sitting our own rooms and we've been working on, bringing in the PGY1s. And so we're like slowly building those blocks of supervision. So it starts with helping them come into their own rooms. And then next year, I think it's going to look like we'll help maybe 1 or 2, like with their plans and things. So I think our plan, at least at our hospital, to get that supervisory role is to start small and then go from there, just really encouraging us to look over the people coming after us.
Dr. Ramsingh or Dr. Flood, do you feel your program specifically tackled this topic of managing an operating room and leading a care team?
I know here at Emory in our CA 3 year, we have several dedicated weeks of supervising the incoming CA1s. So I haven't done that personally myself, but I know that's up and coming for me. But I will say that, something that I've gotten some experience with since being a CA1 is some of our call experiences. I feel like are great times for us to get practice in new and different environments, and especially at our county hospital, Grady Memorial. From early on in CA1, call can be busy and traumas come in all the time. And early on in CA1, we go from, executing the intubation and putting in lines and stabilizing emergencies or dealing with, elective or urgent cases that are coming in after hours. But as I've kind of gone through and seen more of those, some of the calls changes, it becomes less of, I need to get the intubation, I need to get the line to, the front desk is calling me about which case should go next. How do I work with the 3 anesthetists that we have? Are they getting breaks? Have they gotten out for dinner? Who needs to sit which room? Or we have a couple regulars, but we have a locums anesthetist that's coming on, and it's their first time overnight here, and they're in a level 1 trauma. Like, how are they doing? What's their practice like? So I think that we've gotten some good graded responsibility in this role and kind of go from more of an execution. And we still have, attendings obviously on call overnight, but, as we've gotten more experience, they've been good in pushing us to go from the execution to the formulation and like you were talking about, like the personnel management and collaborating with the anesthetists and other peri-op staff.
It's great to hear because that it literally is most of my job every day. I mean, clearly I'm doing an anesthetic. That's the number 1 job, but most of the work that I'm doing every day is exactly what we talk about is this person new? Do I need to come back to the room more to check on that patient? Or this person has been practicing for 20 years and they're an ASA 1 for a lap chole. They know that they'll call me if they have any problems. I'll just come back for emergence. And so I'm glad to hear that you're seeing that because it is such a huge part of, I think, what you'll be doing on a daily basis is that stuff, the softer side of communications and leading and planning and, operations of an operating room, which I'm glad to hear you're doing that. So kind of speaking to that, Dr. Ramsingh, is what else could the ASA be doing, or what else could your program be doing? How could we help you? I know that the committee on the anesthesia care team is working on a toolkit or some kind of a podcast or a lecture series on this transition. But instead of just telling you what you want, like I'd like to ask you specifically, how could we help you, or what would be helpful for you, Dr. Ramsingh, to make the transition? Or what do you want to know about more in particular?
Yeah, that's a great question. I actually learned a lot from what you were talking about today that I didn't know. And so I guess that brings about the question of when do we start this conversation in residency? I'm just in PGY1, so I'm still in the early stages of it. But I think the more that you ask questions, as you said, and you hear about it early on, it helps you to get ready for that transition period. So I think, this podcast itself is a great resource. But maybe something like a simulation, because I know case simulations are big these days, and maybe multiple management of multiple rooms would be helpful, just so that we get an idea of it from earlier on. Yeah, I think that's a good start, at least within the residency program. I know for sure as we go through CA1, 2, and 3, we'd actually be living it. So that's definitely a guarantee during residency.
Yeah, I think it's such an important topic, and just it's something that I feel I did not get enough formal training of it when I was in residency. I think my business background did prepare me a little bit to do it, but that transition of now going to fellow residents that I was supervising, like I think Dr. Flood, you had mentioned supervising a CA1, but now you're managing other professionals who have different backgrounds, different training. It's exciting, and I think it's great because I love what I do. I love anesthesia. I love working in the care team. But like anything, dealing with an unruly neighbor in an apartment complex, I mean, you got to deal with personalities. And some people love to call you for questions. Some people will never call you. Some people, I have some people I work with who are great, but call me almost every 10 minutes. Like, hey, I just want to check, should I give phenylephrine or ephedrine? And I got some that may never call me for emergence if I didn't let them know, hey, I'd like to get text when you're ready to push the reversal. And so Dr. Ramsingh, you said starting to ask things early. And I think asking your attendings, what are things that you struggle with in your role as an attending? Because it is an odd transition to perform something and to let someone else do that as you supervise. The first time I saw a resident intubate when I was doing it myself, I mean, it was a challenge to not want to just take it myself, but you're in you want these people to learn. And so that skill of learning when to let go, when to step in, because again, you are in charge of that patient. And if the harm comes to them under your direction, even if you weren't the one doing it, it falls to you. So knowing when to let go, when to step in, and by asking questions, I mean, I would say PGY 1 year, start asking those questions along with the other questions of learning the field of anesthesia and all the things you need to pass your boards. I think is only going to help you guys out as you make a transition into whatever practice you end up going to.
Yeah. One thing that I thought about from something you said earlier, we were talking about ACGME requirements, and you mentioned how vague the wording in perioperative leadership for anesthesia residents is versus our case logs for procedures. And, do you think that some more objective ACGME requirements for supervision, like X number of days in a supervisory role, maybe would be something that gets implemented?
I think that's something that I think could very well be explored. Someone mentioned simulation, and I think I loved when I was in academics just to talk to residents. Like, so how would you handle this? Like, so you're intubating in one room, and they're calling you to start a block next door. Like, how would you handle that situation? Or describing kind of my day. Like, what if how would you start 4 rooms? Would you try to make sure that you went back in a staggered fashion? So I think asking attendings early and having those kind of simulation/discussions with residents, I think is a great way to communicate, but just talk about things, because a lot of times there's not one right answer.
Wow, this has just been such a great, thought-provoking conversation. I could not have done it without you guys joining me today. Thank you, Dr. Hatch, for sharing your experience, my fellow residents for their help, and to you, the listeners, for tuning in. Come back soon for more Residents in the Room, the podcast for residents by residents. Thanks, and have a wonderful day.
Hello, ASA. I'm Dr. Patrick Gia, your ASA president, and this is the Monday Morning Minute. First, I joined Dr. Adam Stryker to discuss the specialty, the society, and the future during the president's episode of ASA's Central Line podcast. Next, resident component president Dr. Natalie Coons took over the March 23rd Monday morning outreach. She shared her experience as an ASA member and resident component president, the valuable resources developed for residents, and why residents should get involved in the society. Last, in late March, I was joined by fellow executive committee members in D.C. for meetings with federal lawmakers. We addressed low Medicare payments, reining in the abusive behaviors of big insurance, and improving the No Surprises Act to ensure that anesthesiologists receive fair payments. Well, that's it for now, and I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach.
For more detailed and timely information, don't miss Dr. Guillem's Monday morning outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. As you look forward to the biggest transition of your career, choosing and establishing yourself in practice, it's good to know ASA and the anesthesiology community have your back. Smooth your route to success, get answers to anything, create your circle of support, and envision the future of the specialty. Find resources just for you at asahq.org/resident. Join us for Residents in a Room, where we'll share timely info, advice, and resources designed to help residents succeed in residency and beyond. Find us wherever you get your podcasts or visit asahq.org/podcasts for more.